So, what we have learned so far is that we can safely reduce the use of lights and sirens by protocol, that there are more collisions using lights and sirens, and that lights and sirens don't work as well as we think they do, and they certainly don't save as much time as we might expect. Well, let's take a look at what the clinical yield of lights and siren use is. I'm going to share information about a paper that I wrote with Dr. Brown, with Mike Taigman, and one of my paramedic colleagues, Vaughn Hamilton, from Marble Falls Area EMS. Thank you for that kind introduction, Dr. Jarvis. I didn't know how else to start the video with me doing the introduction. Guys, I want to talk to you about a paper that I did with my colleagues Vaughn Hamilton, Mike Taigman, and Dr. Lawrence Brown. We wanted to answer a question that had not yet been answered. That is, what is the clinical yield of using red lights and sirens to respond to a 911 call? We have heard from other guests on this podcast about some things that we know. The other literature that has been done on this tells us that the use of red lights and siren increases the risk of collisions. It increases the risk of delays when you have those collisions. And when you have the collisions, it increases the risk of injuries and even death. This is not good. We have also seen some evidence that at best, we're saving about 4 minutes responding both to the hospital and to the scene. We have also seen some evidence in papers going to the hospital that life-saving interventions were not done in the amount of time that red lights and siren saved. Not very useful. The big question that was still unanswered was how often do we do life-saving interventions in the field when we respond to the scene using red light and siren? That exactly was the question that Vaughn Hamilton asked me when I was out talking to my colleagues there at Marble Falls Area EMS. And it turns out we had the opportunity to do a study and propose a methodology to answer that very question. So we used the 2018 ESO research dataset to answer this question. This dataset is composed of agencies that have allowed us to use their data, anonymized, of course, to answer research questions. We took all 911 calls and we limited that dataset down to just those that had a call nature and patient contact. We then identified every intervention that was listed for those calls, and we broke those down into potentially life-saving or not. Now, we determined whether any given intervention was life-saving or not by a consensus process where each one of the authors looked at the intervention and said, is it life-saving according to a standard definition? The definition we used was any intervention which might, according to standard clinical guidelines, be considered necessary to reverse a critical condition or rapidly improve hemodynamic instability. So that was the definition. We reached a consensus on all of the interventions in the dataset. They either were or were not potentially life-saving. And then we calculated the proportion of red light and siren responses that had a potentially life-saving intervention. And then we subset that against the call nature. All right, so what did we find? Of the 7.5 million 911 responses, we ended up with an analysis data set of 3.8 million calls. Massive data set. Of those people included, the vast majority of the agencies were ALS, they were urban, and they were paid. We found that 86% of 911 responses were run with lights and siren. It's a little disconcerting. It's a little something to work on, let's put it that way. We did find, however, that we do better on transports. Only 13% of transports were done with lights and siren. Now, our big question is what proportion of RLS responses to the scene did we do something life-saving? And the answer was less than 7%. So less than 7% of the time that we scream across our community with lights and siren do we do anything that is potentially life-saving. And the thing I should clarify here is it's not just life-saving in the 3 to 4 minutes that we might potentially save with red lights and sirens. No, it is 7% of interventions done at any time were potentially life-saving. Let me give you an example of some of the interventions that we considered potentially life-saving. So obviously we're going to include any of the things associated with cardiac arrest. That's CPR, mechanical compression devices, airway management, any of the drugs associated with cardiac arrest. We also included things like naloxone and benzodiazepines. Now, benzodiazepines, we recognize that we use benzos a lot of time for non-life-threatening emergencies, like, say, anxiety. But there is also the potential that we could use them for life-saving interventions for things like status epilepticus. So we included them. Very, very conservative definition. Now, if you look at the call natures that we used a lot of life-saving interventions on, I don't think it's surprising to anyone that cardiac arrest and respiratory arrest and gunshot wounds and overdoses were at the top of the list of things that we did life-saving interventions on. What is interesting is at the bottom of the list were things like animal bites and fever and abdominal pain and nausea and vomiting and lift assist. Okay, so maybe those aren't all that surprising. But the benefit of this research is that we said you can identify, based on the call nature, how likely you are to do life-saving stuff with historical data. So because we have said that lights and siren responses are a clinical intervention, just like any other clinical intervention, and should be targeted to only those situations where the potential benefits outweigh the potential risk, we have provided a methodology that we can use to do this safely. Now, I don't want you to think that the list we came up with is the list you should use, or the call natures that we came up with are the call natures you should use. You should use your own data. This is just a methodology to use. Now, using this data set, if we set a threshold for lights and sirens use that said we're only going to respond lights and sirens to those calls that have historically resulted in life-saving interventions at least 5% of the time, we would have seen a 47% reduction in the use of lights and siren. If, on the other hand, we set that threshold at 10%, we would have seen a 62% reduction in the use of lights and siren. What is the right threshold to use? I have no idea. And even if I knew, it would only be good for what's good for my community, not good for your community. I think that's something that needs to be done in each one of your communities. The bottom line, this is a methodology you can use to objectively, using your own historical data, better target this intervention, red light and siren, to the need. I hope this is helpful. Thank you very much.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.